I'm excited to be sharing my summer research with you. It went a little bit differently than I anticipated, but I'm still very excited about it. My topic is prostate cancer incidence and mortality in the U.S. since screening guidelines changed. So here's what we're going to be going through. We'll be going fairly quickly through all of these. We'll cover some background. We'll talk about the premise and aims that we had going into the study. We'll talk a little bit about the methods that we used, some of the results we drew, some of the conclusions that we made, and then I'll share a few of my personal reflections, and then I'll show the people without whom the study could not have happened, and then any questions that you have. So why do we care about prostate cancer? Well, in the US, it's the second most common cancer type in men, after skin cancer. In fact, a lot of resources just cite it as the most common because of how skin cancers are counted. It's also the second leading cause of cancer death after lung cancer in men in the US. Globally, it has the same burden. It's also the second most common cancer type in men around the world. But in developing countries, prostate cancer is actually the most common cancer type. So with this grant, we aim to do our studies in special populations. And although I did my study here in the US, my special population of interest is African American men. And this is because research has proven that both incidence and mortality in African American men are highest. So when we talk about screening guidelines, we talk about PSA. And PSA stands for protein-specific antigen. It's a naturally occurring protein, and initially was believed to be only produced by the prostate, but researchers found that it's actually produced by other parts of the body. One that I thought was interesting was ovarian tumors, which are usually not in men. So with prostate cancer screening, we look at the levels of PSA in the patient. And PSA is a simple blood test. So what the screening guidelines were looking at was, okay, if the level was increased, then we would go ahead and the man would go through additional screening tests. So maybe it would be a digital rectal exam, or maybe it would be an actual biopsy if something was found, if a tumor was found. But then research started to show that PSA levels are also increased in other conditions like benign prostate hyperplasia, any other forms of inflammation, trauma, and actually PSA levels are affected by lots of things, lots of everyday things, like sexual activity, like the age of the man, what medications he's taking, and even within races there were different normal ranges. So about the screening guidelines. So some of the things to note is that prostate cancer is it's a cancer that typically affects older men. So with the PSA test, it was approved by the FDA in 1986. Then in 1994, the FDA approved its use as a screening tool. So then people started to use it, or in clinical settings, it began to be used to screen for prostate cancer. And then there were different updates to screening. In 2008, the recommendation was that in men 75 and older, screening should no longer happen. And this is mostly because if you screen for it, they felt you would probably find it because a lot of men grow older with it and it may not even be symptomatic. Then in 2012, USPSTF stands for the United States Preventive Services Task Force. So it's just a group of people that get together and they talk about screening guidelines for the country. So then they recommended, based on research, and we'll talk about the research a little bit, that prostate cancer screening should not happen in men of any ages. And then this is just to show that research is pretty dynamic, I guess. After we'd already written up our study plan, we were going through IRB and everything, then the USPSTF came up with a new recommendation, and this time they said men that are 70 and older should no longer be screened. But in men 55 to 69, the decision should be individual. And some of the factors they listed were family history, race, ethnicity, and all of those other things, which to me, the way I like to think about it is do it if you feel like it, to which an appropriate answer might be, I wish I could, but I don't want to. Okay, so here are some of the studies. So some of the major ones were the first and the second one. Those were both randomized clinical trials. The first one was done in Europe, the second one was done here in the US. And they found, looking at PSA screening, that it really didn't significantly reduce mortality rates. And then here in the US, they found that there wasn't really a significant change. So if we are asking men to be screened, And then we're putting them through further testing. We're putting them through digital rectal exams. We're putting them through biopsies. And we're finding cancers that may never affect the man's life anyway. Why are we doing that? And then the New Jersey one, my mentor is quite proud of it. I think it was actually done at Rutgers. It showed the same thing. So going in, these are our aims. These were our aims. We wanted to determine incidence and mortality rates of prostate cancer in men 50 and older in the US. And we used 50 as our cutoff because prostate cancer is typically a disease of older men. Then we were interested in looking at trends with the guidelines as our kind of our benchmarks. And then we wanted to look at the significance of the recommendation on incidence and mortality rates. Our methods, we use SEER national data. SEER actually, the registries actually capture incidence data for approximately 28% of the US population. But with the way that it's sampled, it tends to be representative of the entire population. So SEER, the NCI has oversight over SEER. It's actually a publicly available but de-identified data set. And we use SEER 18. So there are different forms of SEER data sets. We use SEER 18 because it had the most coverage around the country, and the years also worked for us because we were interested in 2000 to 2015, so that 16-year period with the guidelines changes having happened in 2008 and 2012. And then our analysis, we used SAS and joint point regression. Okay, so some more about our methods. Our outcome variables obviously were prostate cancer incidence and mortality. And then we were interested in really breaking down our results so we could really look at what was going on. So we broke it down by calendar year. We looked in age groups of 5-year intervals beginning at 50 and going all the way to 85 plus. We looked at race, ethnicity. So black, non-Hispanic, white, non-Hispanic, Hispanic, and other. And one of the things we're really proud about for the way we did it is a lot of other studies would only look at black, white, Hispanic, and if they did, look at other groups. So in some ways, they were double counting. So if you were black, non-Hispanic, you fell into black. And then you also fell into Hispanic. But we actually tried to tease apart those groups so that we could look at the numbers well. And then we're also interested in residence, is where you live, have any impact on incidence and or mortality. And then we looked at risk groups. So the T values there are their cancer, the word is escaping me now, cancer grades and stages. So the higher the number so we have T1, then T2, then T3. So it just really looks at the size of the tumor and the location. So is it only on one side of the prostate? Is it on the other lobe as well? And then the GS stands for Gleason scores, so that's actually looking at the pathology. So when we pull out the tumor and we look at the cells, what do the cells look like? If they look like normal cells versus more like cancer cells, then the ones that are more like cancer cells are obviously more severe. And then we also looked at PSA. And then we were also interested in looking at metastatic cancers. And then there were a bunch that were unknown just because of the coding within SEER. So we started out with about 1.3 million cases when we restricted by males and cancer. Then we restricted by a diagnosis of prostate cancer. And and then we went down to the years, to the age group. We weren't interested in those who were diagnosed by autopsy or death certificate because we wanted them to be alive during the time of diagnosis. And then we're also interested in it being only a primary tumor. So we started out with about 780,000 incident cases. For mortality, we used the same data, and I'll talk about that later because it became a limitation for our study. We looked at those who had prostate cancer who died, when they died and how old they were, and then also those who died of prostate cancer. So if you look at the last two boxes on the right side, 379,000 were all-cause mortality cases, and then about 84,000 were prostate cancer-specific mortality cases. So here's our results, our fun part. First of all, we did overall incidence rate. We age adjusted it using the 2010 US Census data as our standard population. And you can kind of see, I'm just going to step over here. You can kind of see that the graph, it kind of holds and then it falls a little bit and it goes up and it falls some more. And then we decided to do regression so we can actually look at where the breaks in the line are. And what we found is that the first segment was recognized as between the year 2000 and 2009, and the negative number indicates a decrease. The hat sign indicates statistically significant at p less than 0.05. And all the numbers on the y-axis are per 100,000. So we found that there was a decrease, and then after about 2009, the decrease kind of takes off. We go from about 1.59 average annual percentage change per year as a trend within the first 10 years, and then after that, it goes down, the decrease becomes about 3 points. So at this stage, we start asking questions that maybe PSA screening has something to do with this, since the first guidelines changed in 2008, although those guidelines were aimed at people 75 and older. So then we looked at age specific, and this is where it became not so convincing. Because if you look at the bottom, that graph there, if you look here, the lowest graph there is the youngest age group, which is what we expected, because is the youngest age group here. Okay, so this, so the youngest age group here is 50 to 54, which is what we expected because it is a disease that occurs in older men. But then when you start to look at 75 and older, with the trend having, with the change having occurred in 2008, it starts to fall. It falls a little bit. Like we can see that it starts to fall down. And then we look at 80 and 84, and maybe, there were just not that many people in that group because they're an older group anyway. But when you look at the actual trend, the analysis, the 50 to 54, the first segment wasn't even statistically significant, and then everybody starts to fall, if you notice. Everybody's falling, and then when you come down here to 80 to 84, it seemed like they'd already started falling in 2000. So we're asking ourselves, why? Could it just be that maybe in older groups that people just are no longer fans of medical interventions? And everybody's falling, but when are they beginning to fall? And with this graph, even if with the guideline change of 2008, even if it took a while for the implementation, maybe we expected a sharper fall in the older age groups. And then why are the younger ones falling? Is it because they thought if they don't have to get screened, I don't have to get screened as well? So then this kind of begs the question that, was PSA screening really affecting incidence rates? And then we looked at race and ethnicity, and as I was mentioning before, you can see the black non-Hispanic are all the way up here, almost twice. The incidence is almost twice as much as the white non-Hispanic group. And then you can see the same fall here. This was interesting to me. I mean, I guess if you live in an urban area, you're more at risk. The urban group had more people in it than the rural group, but we see the same kind of general fall, but within, it's like this one is 2007, this one starts at about 2009, and we don't see the clean break where the actual guidelines changes happened. This was particularly interesting. So the top group here is the intermediate risk prostate cancers. The bottom group here is the metastatic. And if you look over here, you find that after the last change, which was in 2012, when all men of all ages were told no longer to be screened, the number of metastatic cancers begins to rise. What we would have also expected is that the low-risk groups should have fallen, because if we're not screening as much, then maybe we're not catching them when they're at a lower risk. And even though it did fall, we don't see that break at the years of interest. And then even though intermediate falls, it still doesn't fall that much. So this is concerning. And then this would have been the meat of our presentation. And remember I was saying that we had some limitations here. So like I mentioned before, we used the same SEER data to look at mortality. And what we could not really we tried to understand it, but we still have some things to tease out with this, is why all-cause mortality was increasing. Because we know that in the US, life expectancy is rising. So we would have expected that mortality rates should either remain steady or should fall. So this is something we plan to redo using data from the National Center for Health Statistics. where they actually collect death certificates. And then this graph looks like what's in the literature, but then you can see, you know, there's some decrease. But we also want to redo this as well. And this would have given us a better idea about whether or not screening is actually affecting the key outcome, which is mortality. So what are some of our conclusions? Like I've mentioned, the incidence does decrease. It decreases in older groups and younger groups. It increases in metastatic cancers and intermediate risk cancers, and it doesn't decrease. It doesn't. We don't see that fall really, that sharp fall in low risk cancers. And then, like I mentioned, we will need to redo mortality. So what are some of the things I learned? There will be setbacks, I think, which has become a common theme today. It does take time between when we got the IRB and just trying to get everything going. A lot of this analysis was actually done in the last few weeks. And it does require thinking. You know, if you get numbers that don't make sense, you have to ask yourself, why doesn't this make sense? So some ideas for future researchers, looking at the new guidelines, looking at this age range. And then also something I would be interested to see is research has shown that even though the guidelines have changed, that a lot of people are still very interested in receiving the PSA screening, even when the guideline was all men of any age should not be screened. So if we had those numbers to look at a region, to look at the amount of screening that was going on actually, and then look at incidence and mortality, I thought that might be pretty interesting to look at. Then some of the strengths of SEER, some of the strengths and limitations, it only represents 28%. We will need to redo our data. And then our mortality, these are some of the reasons we came up with for why our numbers were a little bit off. And then future plans, I would really like to see this, is once again looking at this age group with the new guideline, and I'm thinking this is something that we would want to do, and looking at metastatic cancers and breaking it down by race, ethnicity, because this could be something that people should keep in mind when they decide whether or not to be screened. And then obviously, the future plans would also be to complete manuscript. And then also to complete our mortality data and break it down in the same way. And then these are our collaborators. This is my PhD advisor, Dr. Dempsey. He was our biostatistician. Without him, we could not have done all of this. And then some of our other collaborators, of course, Dr. Solomon and Dr. Chamberlain, as well as CESP, CUNY, and all of you. Any questions?
Thank you. Great presentation.
Thank you.
Seems like your hypothesis, what you're proposing is showing like the downward trend. But just a quick question. Have you looked into the sample size methodological survey methods that usually the national databases, the sample they collect, they might change the way they collect the methodology. So have you looked into that if there are any changes related to that? Yes, for the CDC, cancer, like SEER databases. Usually the number of samples they collect, the states they are involved might change from time to time. Especially you are looking at the trends over the years. So you should also look into that.
Right.
Have you looked into that?
Well, with SEER 18, it was looking at 18 different regions, and some of them came in at different times. But the thing is, for our year, for our duration, which was 2015, because that was the most recent data that SEER had, we did have complete data for those different regions.
Thanks.
Have you considered, instead of just looking purely at age, but look at birth cohorts so you can see the effect as men age were exposed to different guidelines over time and what the yield was?
I think that's a great focus for this. The only limitation with SEER also would be that SEER doesn't record days. So it will give us the month and it'll give us the year. And that was a limitation we had with mortality, but we may not see actual dates. And I guess we could still look at the years with birth cohorts. Maybe that would be another way to go with this study, maybe to ask those same questions.
I almost got the impression from looking at the shape of those curves that you sort of wasn't a great connection between screening guidelines and screening practice, either before or after a new guideline is, there weren't abrupt changes in any of the curves or anything like
Right.
that. So it sort of, men kind of got screened if they felt like to before, and now that the guidelines have changed, they're kind of doing the same thing at a lower frequency, but not because of the guideline change. I mean, is there anything that you saw in any of the data that would suggest that there was some kind of break in the curves that related to the change of guidelines?
And I guess that's why we weren't able to conclude that, that screening guidelines actually did affect incidence rates. One of the research papers that I did look at before we started said that I think up to, I forget the exact numbers, but that in different regions, I'm sorry, so the paper said that a lot of men are still expressing a lot of interest in receiving the screening, and a lot of doctors are still very interested in receiving it. So I think that, one of the reasons why we wanted to do this is that we did predict a lag between when the guideline came out and when people would actually follow it. We didn't see that. We didn't see the lag. We didn't really see anything sharp, which is why we can't conclude. But I do think that that would be something interesting to look at, to try to see what was actually going on if there's that kind of data.
Has insurance reimbursement changed over this period of time for the PSA?
That is a million-dollar question. It's possible. I think insurance reimbursements have changed for a lot of things in the medical world, from procedures to surgeries to screening tests to everything. So there is that possibility as well.
Yeah, because that can drive compliance more than anything.